Hello everybody. I'm just doing these kind of YouTube videos or videos here in general, just as a little bit of a side hustle to my job. I feel like there are some topics in radiography that aren't really covered very well in unis or lectures, and there's all things that you really find in practice that gives you tips and tricks on how to perform things. So I'm doing this as a series to hopefully try to bring some light to some of these projections or any sort of theory that people might not understand as well. Me, myself, I'm a radiographer. I do X-ray and CT. So if there is any other things that you kind of want to discuss in the future, please feel free to let me know. But today we're going to be talking about the humble lateral chest X-ray. Now, the lateral chest X-ray is obviously a projection done in conjunction with the PHS, though the frequency that it is performed varies greatly between departments. I've worked in places where it's done routinely for patients and some where it's just not done at all. So obviously practice depends on where you're going to. Most often though, after a chest, if there is anything found, it is mostly followed up by CT just because of the increased contrast resolution and spatial resolution, though the doses are obviously much higher. Now, this is going to be very boring. I'm going to make this quick, but there are some statistics that I would like to just put online. A systematic review by Lynch et al. In 2003 found a standalone PHS X-ray has an average sensitivity or a true positive rate of about 90% and a specificity or true negative rate of 96%. This is, however, only in detecting pneumonia. Of course, these things will vary between your pathology, such as pleural effusion or any other things like that. The most interesting thing to note, though, is the NNT, or the number needed to treat. Lynch et al. Described this as being the number of patients who will need a lateral chest for one patient to benefit from the projection. And this was found to be 38. So realistically, you'll perform 37 other patients and it will provide minimal to any sort of increase in diagnosis. And obviously, just in a sense, the effective dose of the PA is 0.14 millisieverts and the lateral as 0.22 millisieverts. And this obviously denotes the overall radiation deposit to the patient, accounting for tissue factors and radiation sensitivity factors. Now, the purpose of a lateral is pretty simplistic: to localize lesions or pneumonia. As you can see in this case, we're localizing a left lower lobe pneumonia, and you can see that it's a bit more obvious to see on the lateral, though you still see that kind of difference in density posterior to the heart on the PA projection. You're also assessing the anterior mediastinum, or the retrosternal space, which is this space kind of behind the sternum over there, to any lesions or anything like that. And the thing that I personally don't really do, but it's good to note, is the T-spine. So this is something called a spine sign, and it's based on the change in attenuation of the T-spine from the shoulder girdle to the lungs. On obviously any patient, the shoulder girdle will provide a high density difference, and you'll get a more radio-opaque upper T-spine, as opposed to the bottom of the T-spine where you get more radiolucence. And the radiolucency will obviously increase the lower you go when you encounter more lung. Now, this is a good demonstration for things like the left lower lobe pneumonia here, because you can see that the density kind of goes down, 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 and it comes back up to be more opaque, which is denoting that sort of pneumonia there. Positional critique is obviously just, you've learned these in textbook, but in a sense, there are a few things that I feel is probably key to this positioning if you do this in the future. First thing is obviously inspiration, all lungs visualized. When we do these projections, do try to collimate out the anterior breast tissue, as they are very radiosensitive organs, and I do like myself a nice coned in lateral. Second one is obviously arms and soft tissue not superimposed over the retrosternal space, and this becomes a bit of more obscurity in that area, and you won't be able to properly define the density in the retrosternal space. Posterior ribs is the main thing to assess for rotation, and they should be obviously superimposed over there, and literature gives us a little standoff for about greater than 1 centimeter, and that's something that you might consider repeating, though obviously that depends on what you are assessing there. And finally, the thing that I don't really personally see the most is something called the tilt, obviously, and that's the patient leaning left or right. And you know your patient isn't tilted in an ideal world if you can see through these T-spine intervertebral disc spaces, just like if you're critiquing a spine in general. Now, to the main purpose that I have here is assessing rotation, because We all know how to take a lateral chest x-ray. We all know when we see it, okay, that's good. But sometimes, even in practice from radiographers that have been in the business for a while, you get a rotated chest x-ray and you go, actually, which way do I turn it? And this is something that isn't actually quite taught in uni, even for my case at least. And looking online, nothing really shows you quite clearly what you assess. So I'm just doing this as a whole of loads of tips and tricks that you can use. Now, there are multiple ways of doing it, and anyone you encounter will probably have their different ways of assessing rotation. I'll run through a few that are relatively more broad, and then I'll go by why I wouldn't use this or why I would use this. First one that we can look at very obviously is just diaphragm positionings. Usually your right hemidiaphragm, so the red dot here, will be higher than your left on a PA, and this is usually just due to because the liver is sitting right below the right hemidiaphragm. An elevated left hemidiaphragm is something to consider for any pathology, such as left lower lobe collapse or anything like that. But on an untilted patient, the right one will be more superiorly to the left, but this obviously depends on your tilt. If your patient's tilted, this will project the diaphragms off differently. The second one that you can assess is the gastric bubble. So gastric bubble usually sits inferior to the left hemidiaphragm, and you can see very kind of faintly on this part that it's kind of located right inferior to it as opposed to the right one there. But this again, you're relying on things that the patient doesn't have, situs inversus and things like that. Now the one that I personally like to use, and it's a bit more of a tricky one, is something called the silhouette sign. Now what might the silhouette sign be? It pretty much denotes that two structures or two similar densities that are abutting or touching each other, you can't really differentiate their borders. So in my lovely little drawing here, so you have two shapes of equal density or color. If you see them right next to each other, you can't really tell they're two shapes. However, once they're out of that same plane, then you might be able to differentiate the borders between them. This is mostly used, or most useful used in things like pneumonia here. So your right lobe has the middle lobe and the upper lobe, which kind of coincides with each other at the lower zone of the lungs. But if you can see here, for the right lower lobe example, you can still kind of define that heart border to the side, as opposed to the right middle lobe here. You can see that you have a pneumonia on this side, but you can't really tell where the right side of the border is. So this is something called a silhouette sign. Since the right middle lobe directly abuts the heart, if there is any consolidation in there, you will lose that border. Now this is good for the lateral view, because you can see here that the right hemidiaphragm, pretty much you can visualize it all the way to the spine itself. The left itself, since it is abutting the apex of the heart, you lose that contour around the middle, and you can't really differentiate where that diaphragm kind of ends. You might be able to vaguely see it, but you got to put some effort into it. And this pretty much coincides with that lateral. So the right hemidiaphragm, you should always be able to visualize it from the posterior aspect to the front, and the left you'll kind of visualize it from the posterior aspects, but lose it about where the heart contour is. And this is the one that I personally like to use, and I find it is most consistent, though there are problems if you encounter things like pneumonia on, for example, that right lower lobe or right middle lobe, and you lose that sort of contour at the front because of the silhouette sign. But pretty much that's just about what the lecture is for today, or my little talk. I'm not very good at presenting, so hopefully in the future I will kind of go up to other videos and other topics that I find interesting, and hopefully present it in a little bit more of a formal way. But if anybody has anything that they would like to chat, please feel free to just let me know. Thank you. Have a good day, guys.